statement. I hope to share with you like where that comes from if you don't already know, to help you amplify your work and your voice. So how many hygienists are in the room? Yeah. All right. How many dentists are in the room? All right, cool. So we're in a safe space because the only dentists that are in the room are people who have been helping empower hygienists for a long time. No, really, because I'm going to say some stuff. I'm not kidding. It is a hard thing to come to the Oregon Dental Hygienist Conference as a minimally invasive dentistry person and think that I can teach anything to you. When I talk to people around the country, people often ask me, like, what are the really innovative projects that are going on around the country? And I listen to what they know, they listen to what I know, and it just keeps coming back to like Predict, for example. We'll talk a little bit about what Predict was, but the community care team from Advantage, like, remains, very few people in the world are doing what was started in, 2015, 2016? It was like 5 years ago, 6 years ago. And still, it is exceedingly rare just to take a simple kit to where people already are, schools, wherever, and instead of just screening or sealing with plastic, to actually provide medicines as treatment for the most common disease on earth. So for me to be like, what the hell am I going to tell you, Really, I do think one of the points of me being here is to help arm you for the logical points that you all make in order to get permission to do the things that you can do better than anyone. Often we have a dentist in the way of a hygienist. It's just real. That's the situation we're often in. I want to help give you tools to have those conversations to get the dentist on our side, on your side. I want to give you some tools, some logical points, some information, take the slides and whatever, to help you get the systems, the DSO, to support your voice, to support your work. And maybe, just maybe, I'll share a couple things that some of you haven't heard before in terms of detailed information, but please try to pay attention to the arguments that I make more than the information, because the information has been empowering y'all for a long time. But I think we're just at this next stage where we build it, it gets taken apart, we have to rebuild it, it gets taken apart. And so we need to keep amplifying and keep fighting forward for bringing care to the community, for bringing medicines to people, for bringing change in nutrition and hygiene that people can do for themselves, which really is the only way forward to combat the most common disease on the planet, dental caries. So that's what I'm here for today. I have some disclosures. I do work with a couple companies, Colgate, GC America, and Elevate in particular, to help them amplify their work. And then I work for a company called CareQuest that owns Advantage Dental still. That's going to change, and they own DentaQuest and some Delta Dentals in other states. So I am really biased. And in our part of the company, in my part of that large company, we do impact investment. And so what my best example of that is we're trying to find and support the next silver diamine fluoride, which Advantage Dental did, right? There was the leader of Advantage and this wily professor from University of Washington. They got together and used all of the resources, manpower, financial resources, et cetera, of Advantage to get silver diamine fluoride through the FDA so that we can all use it. It was a lot of resources and person power. So we are trying to do that not only for stuff to stop cavities, but other things as well for oral health. And so we've invested in a teledentistry company. We've invested in something that you'll be able to brush on to teeth and rinse, and then it'll show where the cavities are. in a blue spot, which when you don't have diagnosis for hygienists, but you can go to community settings, can empower hygienists in other states to then treat. You know, if there's a blue spot, you can have standing orders, then you can treat that blue spot, for example. So we're hoping to introduce that towards the end of next year. And other things like that. So here's the outline for the rest of our time together. I very much invite conversation and questions, and if I'm talking about something that's not interesting to you, just shout out a question or raise your hand or whatever's good for you, please. Or you have a question about it, please. So we're going to talk about just some highlights. I know when I wrote the title for this talk, I said, like, I want to tell the whole history of organ hygienists, but I'm not the right person. I'm a dentist in California and a researcher. Like, who am I to tell you your own history? That's not. So I'm just going to share a couple highlights of things that I know about that I'm really excited and motivated by in my work every day. We're going to talk about some medicines for tooth decay, including silver fluoride, glass ionomer, iodine, and this thing called Curidon. My email is here. That'll become relevant as we go through, but I am also working to try to create resources to empower these tools and you going forward. Has anybody seen this before? It's the scope of practice wheel for dental hygienists across the United States, across each state. It was updated last in like early 2019, so it's a little out of date. And so like there's these two, what are they called, spokes. This is Oregon and this is Colorado, where just like everything's filled in terms of like empowerment of hygienists in the state. So, I mean, you guys already know this, but part of being here for me is saying like we need to help all these other states, and some of you have stepped in. We've been involved in like 13 dogfights to protect the rights for hygienists to place silver fluoride in community access settings. As a particular example, I mean, obviously that started here in Oregon with the silver nitrate hoopla, and they said, you can place silver fluoride, but not silver nitrate, even though now we know silver nitrate and fluoride varnish works just as well as silver fluoride. Thank you, Dr. Steve Duffin, for inventing that. But they said you can place silver diamine fluoride, but it wasn't through the FDA yet, so we didn't have it, which is their attempt to control. But we're still fighting these fights, and really in like the other, 33 states, to protect the rights of hygienists to place silver fluoride in community access settings, or just to do anything in community access settings where people already are. So just a reminder, we have it good here, not everybody else does. There's an ongoing fight. We need motivated people to continue filling in this wheel and building more rungs out. Now for some highlights. So, do you know, like, again, the reason we have silver diamine fluoride in the United States and the reason that like scores of other countries are bringing silver diamine fluoride in is because of Advantage Dental. And why even Advantage Dental? It's because of the setup that Oregon created of having capitated, global capitation for health, global capitation for oral health, because of all the things you guys know I'm not going to read. But we also specifically, hygienists, Sherry Ludwig, Marilyn Rothen, Ashley Danielson, Mindy Bentley, Stephanie Browse, Kim Holliday, Tiffany Foy, and Brenna Southwick. Anybody here from that list? These hygienists did the only FDA safety trial in children to demonstrate not only that this stuff worked, we knew that already, but that it was safe to treat children in a placebo-controlled trial in Head Starts in Oregon. This has enabled so much progress in providing care to people where they need it and who needs it. And that was done by hygienists. Hygienists did that. Here, your team. It's amazing. Because of this specific study, we were able to apply for breakthrough status. You gotta understand what breakthrough status means. Breakthrough status, the FDA only gives breakthrough status for drugs that show promise to treat diseases for which we have no treatment. The FDA said we have no treatment for cavities. NSDF is the breakthrough. There's a phase 3 clinical trial where we'll be able to, long story. The FDA said we have no treatment for cavities. This is how the federal government looks at it. They believe, based on all of their logic and information, that fillings are not a medicine for cavities. So to me, this is like a fire. Like, we got to do better. We have to have more. We have to do better. And so this was, what was it, 2016, 2017? I don't remember. That the FDA status was given. And that was, again, because of hygienists. Click through here. So there's also this study that was done, I mentioned earlier, called the PREDICT study, where a team of, it was like 27 EPDHs, expanded practice dental hygienists in Oregon, went out to schools, Head Starts, WICs, and provided, based on whether there was like a big hole in the tooth, and whether that hole had completely accessible enamel all the way around it, they would provide different care. And so, you know, if things were really bad, they you know, if there's signs of infection, there was case management to get kids into dental clinic for care. And if there was not an infection in the bone and abscess, then we had SDF, iodine, fluoride varnish, and glass ionomer sealants. We were using Relidex at the beginning, and now we're using other materials that don't need a triturator. And if there was no big holes in teeth, we just placed SDF. If there were caries lesions, and if there was nothing, we gave them some toothpaste and all of that. Like this, again, this is the state of the art still, and it was launched like how many years ago? And this was all done by hygienists. Are there any dentists going to schools and doing this stuff? No. You know? So this has been a big deal. So I think this has been really successful, and I'll demonstrate the success of that with the next slide. This is a chart that an Oregon hygienist named Charity Ludwig put together with her team about the incidence of general anesthesia to treat cavities across all of Advantage. So I don't know, it was like 1/3 of a million people, something crazy. And it started out around 2.4% in 2011. Through the introduction, copying Dr. Steve Duffin of silver nitrate and fluoride varnish, they were able to immediately drop across this large population quite a bit. They also introduced xylitol for new mothers. They got coverage for new mothers within the first 2 years after birth, or something like that. Sorry if the detail there is wrong. They created a training manual on prevention. They implemented pre-authorization. They expanded a bunch, and so they got a bunch of new lives that had really bad cavities already. They started some in-office sedation that didn't. Who knows if that helped? And then they created the community care team. PREDICT, community care, it's sort of somewhat synonymous. And that empowered hygienists to go out to schools and do the things we just talked about. Silver fluoride, glass ionomer, iodine, fluoride varnish, case management to get people who have infections to care to treat the infection in their bone. And then you can see this all falls down. So, ultimately they lowered the use of general anesthesia. Has anybody been to the operating room for a dental case? Steve, I know you have. It is not pretty. Putting a baby to sleep is not pretty. It can be smooth, you just gas them down, it's like they're dying. And then they're out, it's like they're dead for the entire time you're treating their teeth. And then when they come out, it's mayhem. They're completely freaked out, usually for hours, and it's like they just had a really bad sickness for the next 2 days. It is wild, it risks their life. Children do die in this. It's rare, thankfully, because the anesthesiologists are amazing. But it's ghastly. Hygienists going to schools and offering these simple treatments for cavities and some case management reduced the incidence of that by 75% across just a few years. That's what's been done by you guys just going to schools, Head Starts, WICs. So let's just take a moment to congratulate the Oregon hygienists. It's a really big deal. It's a really big deal, and it's setting an example for the whole world. So right on. Medicines for caries management, what the hell does that mean? Like, what are you talking about, Jeremy? What's a medicine? Again, the FDA said we don't have a treatment, they dictate drugs. We don't have a drug. Medicines for caries management, we'll get to that. So a little bit more about what we were just talking about, reducing the use of general anesthesia for caries treatment. This just came out a month ago from Australia. They saw what we were doing here, they started copying it. So it was a university hospital. They took all the kids who were referred for general anesthesia for dentistry. They took out the kids who weren't referred for caries. They took out the kids who already had pulpal pain and abscess. So anybody who had severe early childhood caries and wasn't already having an abscess, they just offered, this is the intervention, they offered silver diamine fluoride. That was it. They just offered it. And 11% of the families said, no, we'll just go to general anesthesia. Which means that 89% said, yeah, let's try it. So like I can go anyway if this doesn't work? Yeah. Of the 89% that chose the silver fluoride, 2 out of 102, 2 kids still had to go to the operating room. And 100 kids did not have to go to the operating room. So when parents said yes to silver fluoride, it was 2 still had to go, 100 were saved from the operating room. And people have autonomy, they can help decide where they go, right? That's the whole point, these conversations have empathy. So 11% chose the other way, but overall, we had an 87% reduction in the use of general anesthesia just by offering SDF. That's pretty powerful. We'll show this on the next. Sorry, I'm being redundant here. Yeah. So again, if you've ever been to the operating room, it's really intense. There's a lot of staff, it's really expensive, it's really intense on the kiddo or the person, and we're replacing that with a microbrush. That's what we're doing. And a drop of some chemical. This is not the first time this has been done. I already showed you the effect of organ hygienists on general anesthesia use across a wide population. To my knowledge, the first team to do it, led by Dr. Steve Duffin, did this 10 years before, where Dr. Steve Duffin learned about silver diamine fluoride, started using that, was told to stop using silver diamine fluoride, invented the combination of silver nitrate and fluoride varnish because you just need the silver and the fluoride. You realize you can put that together. That's all approved in the United States, ready to go. And he reduced his use of general anesthesia to manage caries in the children that he was taking care of 100%. He stopped going. Have you been back to the operating room, Dr. Duffin?
Nope.
So if that's not a medicine, I don't know what is. This is with the microbrush. And it's thanks to Steve and just a few other people that we mentioned earlier that we all have this and that we're all doing this around the world now. This is another example of using silver fluoride to decrease the use of expensive, undesirable resources. So this is in, I think it was the University of Florida. And I have to mention, I won't mention the name, but the guy who led this work yelled at some of my closest mentors and friends about using silver diamine fluoride about 10 years ago, that their licenses should be revoked. And has come around so far that he wrote legislation in Florida to protect the right of hygienists to use silver diamine fluoride in their practices and in access settings. And did this work where he said, okay, the pediatric dental residency, you're sending people to the OR. What if we just randomize who we offer silver fluoride to in effort to try to reduce emergencies while you're waiting the 9 months or 3 months or whatever to go to the operating room? So they were okay with that. They didn't want to keep kids away from the operating room. They just wanted to try to reduce emergencies. And they reduced by 77%. So they randomized which kids got silver fluoride upon referral to general anesthesia, and 77% less emergencies while they were waiting for their general anesthesia that they get. we got this announcement just a month ago. Per all of this work continuing to come in, per the massive amounts of clinical trials that have been done on silver fluoride, and we'll talk a little more about glass ionomer in a little bit, but that the World Health Organization has decreed that glass ionomer cement and silver diamine fluoride are essential medicines. So they've said that for a healthcare system to be considered functional, not great, just functional, you need to offer these medicines. So it's thanks to all of this work that's been done that now countries in the developing world where sugar is causing rampant caries now, we're starting to see the impact in very big ways. Now they have some tools to fight back against the effects of sugar. We should probably be going upstream, really, but this is a start. And so this really validates the fact that these are medicines and that these are not just, preventives. These are treatments for disease. The World Health Organization said so. I mean, they get some things wrong sometimes, as we all saw in the last 2 years. But I think they did this one pretty well. And so this is something that you can use to share, upstream as needed or with your colleagues. That stands on the shoulders of the American Dental Association coming out and saying that clinicians, the American Dental, they didn't say dentists, clinicians are encouraged to prioritize the use of non-restorative treatments, basically like silver fluoride, based on effectiveness, safety, and feasibility. So they didn't say we need more research, as Dr. Young has pointed out to me many times, and thank you, Dr. Young, for contributing to this and making this happen as a co-author there. And so we have the WHO and the ADA saying, go, use it. So hopefully this can be useful in your enterprise as well. Okay, so I have this new role, as I mentioned earlier, at what's now called CareQuest, and I am trying my hardest to make use of all of the resources to push things forward and empower, enable all of us together. One of the things in having this whole speaking campaign that I've been on, and we've been on for years now, that I get is well, how do you put it on teeth, right? It's like the hygienist, everybody asks, well, does it work? Is it safe? All the reasonable questions. And then it's well, how do you actually get it? What do you do when you're there? How do you set up your regimen? The dentist asks, how do we bill for it? What's the code? All of that stuff. It's all great stuff, right? But how do we actually do it? And so as I've worked with public access, expanded practice hygienists and dental therapists who are out there treating people without a dental clinic, there's this question of how can we really simplify, streamline the application of these medicines, how can we do these techniques around silver fluoride and the other things that we have that we'll talk about. And so we created a playbook, an illustrated how-to guide for how to do these things, and I will show you some of those going forward. But it's to empower new hygienists, new dental therapists, to learn how to do these things, to give to their curriculum. It's to use for the masters of these techniques so that they can show their colleagues to validate it, that this huge organization has said, not only is this okay, but we need everybody to understand, how this works so that you can do it. In the coming year, we're going to be creating a website with all of the key references, the MSDS, all the things you need, videos, so that you can use as a reference in particular to convince others to assess and evaluate and see whether this is a good fit. This is kind of the first page of the playbook. You can see some of the illustrations here and our nice disclaimer, it's a big company, don't sue us. We're trying to help. But we have this illustrated playbook. I hope that it's useful. We have a flowchart at the beginning. We are still working on this. It's kind of big and complicated. If you look at nurses' manuals, a lot of times they have flowcharts. It was actually Carol Fricella, Sensei's wife, Dr. John Fricella's wife, who told me I needed to do this. And so it's really busy, it's not pretty, but we're working on it. And the question is sort of if you have a cavity, so it's not if you have a person. We need to work upstream, we're working on it. But if you have a cavity, caries lesion, whatever. You ask these series of questions to figure out how, what options there are for you to consider. And the ones in dark blue down here are ones that at present we have how-to guides for. We have an activity guide for, not for you to like play with your kids, but an activity guide to see like what, for an enamel lesion, what is arrested and what is active. For a cavitated lesion, what's arrested, what's active, what should I be looking for? And so on. And we have this guide, all right? So if it's not active, if you have caries arrest, is there an elevated or low caries risk, and what should you do? Like, so if they have low caries risk, we need to like reinforce. You're like, hey, you're doing a great job. What's working for you? I want to like learn from what you're doing that's working so well because you had this caries lesion, you had this disease activity that's now stopped. You are doing something great. Let's talk about that. Let me learn from you. Let's see if you can become a champion for this. Let's reinforce the good work that you are doing. And if there is increased disease risk or disease activity, you'll notice that every one of these says motivational interviewing. And I definitely am going to be knocking on Dr. Allen and others' door to figure out like how can we create like a how-to guide, like 11 by 17, an illustrated guide of like how to just even start to try to do motivational interviewing. Because behavior change around nutrition and hygiene in particular are more important than any other things for long-term disease outcomes, in my opinion. So this exists as a PDF right now. Happy to share with you, just email me. That's why my email is here. So just if you want it, I'll email it to you. We're continuing to develop it in a more big way, and we will have a big launch where we send it out to the whole world when it's ready to be put on social media, which it is not right now. So all this to say, so like we can reduce general anesthesia use, we can control caries, there's a whole bunch of evidence, the ADA, the WHO, CareQuest, DentaQuest, everybody's convinced, right? So let's talk more about like how we can use these things now that we know that they're established and we're all making an impact. How can we really use these things going forward? So we're going to talk the rest of the time really about that. I am not going to go through the clinical trial evidence on silver diamine fluoride today because a lot of you have heard it already and it is online, and I don't want to make anybody go to sleep or tell anybody anything that they haven't asked for twice. This is an example of the how-to guides. This is for silver diamine fluoride. We worked pretty hard to simplify the language, and this was really a partnership primarily between 4 people, myself, Laura Scarrett, a dental hygienist, who's amazing. Medical illustrator designer named Zongyang Lee, and John Fricella, a dentist in Oregon and Maine. We've gotten feedback and input from a lot of other people, but the idea is we're trying to show that you have caries lesion, you dry, you apply, keep it simple, let it soak in for 10 seconds, remove the excess, cover it with something, or protect that reaction for a minute. So we're trying to distill the message of how you use this medicine, you have teeth, you have all these parameters, down to something relatively simple that you could have, that maybe you could show patients to help them to understand what is being proposed, like an illustration of, okay, you're gonna put some cotton in what is that stuff? Is that cotton? You're gonna put some cotton in my mouth, is that sharp? You can let them ask questions and empower them to know what's going to happen ahead of time, etc. And I think I just need to say I did my first in-person. This is my second in-person course since the shutdowns, and the first one was just yesterday in Seattle. It was the Pacific Northwest Dental Conference, and I can't tell you how many people were saying, well, I like silver fluoride, but I always want to use it intraproximally. And people, the kids, the adults, there were tons of people using it on adults, just like 40-year-old adults, whatever. They always get these black stains on their cheeks, and it lasts like 4 days or 2 weeks. What the hell are you doing? This is the floss. They're using floss. You don't need to use floss. Like, I've been trying to be respectful for years to my friends that like use the unwaxed floss and put it in there. They put the fluoride, the silver fluoride on the floss, they pull it in, and then they use that same floss for the next tooth or whatever because they're trying to not be wasteful. And then the silver fluoride gets all over the end. Stop. You don't need to do all that. It's just simple. It's like if you ever take a piece of paper and put it on water, the water goes in through capillary action. So dry the area of the teeth as well as you can and put the darn stuff nearby, and it'll go through to the contact point and into the initial caries lesion based on capillary action, just the same. You don't need to put a floss in there. You don't need to wedge it. If you want to wedge it, great, but like, just don't get it all over people's faces, all right, please. If you haven't heard, this stuff stains. It's crap out of everything. There's that over there. And then the next couple points are about how to use what we understand of the mechanisms to open more possibilities and to improve our case selection, our outcomes, our conversations around this. So a lot of you guys have seen this before. I love this slide. I'm a laboratory scientist at heart. I want to be in public health and in the lab, and for some reason, people keep putting me here at the stage. It's a little weird. I don't actually want to be. I want to be in the lab. Anyway, so here's the story of this slide. This is a slice of dentin. The colors are bacteria, where green is living and red is dead. So they took a slice of dentin and they put it in strep mutan soup. So they got like top ramen and sugar and like strep mutans and put it all together and dunked some dentin slices in there and kept adding sugar and top ramen and strep mutans for a week, until the strep mutans permeated down into the dentin through the tubules and started eating away, dissolving the hydroxyapatite at the top and creating microcavitations, little holes alongside the dentinal tubules up there to where it's just teeming with bugs. They took it out of strep mutan soup, rinsed a little bit, dabbed it dry, put silver fluoride on it, waited a minute, rinsed it, dabbed it dry, threw it back in the strep mutan soup, sugar, top ramen, strep mutans, sugar for a whole week again, and then took it out. This is what it looks like after a week. This is after 2 weeks, but in the middle they put silver fluoride in. So this demonstrates two of the mechanisms of silver diamine fluoride and one of its weaknesses. One mechanism, it kills most of the bugs on contact. Probably kills all the bugs on contact. Two, it really makes it hard for bacteria to grow back. It makes the bugs much more resistant, makes the tooth much more resistant to bugs growing in. So if you look at chlorhexidine, for example, it'll kill all the bugs on contact, but it doesn't stop them from coming back. Silver-diamine fluoride stops them from coming back. So that's mechanism two. The weakness is that eventually, with enough sugar and top ramen and strep mutans, the bugs can come back. They do so more slowly, but eventually they can overwhelm the protection that we've given the tooth and start to grow back in from the top down. Which suggests that if we try to translate this clinically, we need to reapply periodically. Or if we can, we need to stop pouring in the sugar and the top ramen and the strep mutans, if we can. And we need to work on that. And the less sugar, the less top ramen, the less strep mutans, the less silver fluoride we need to balance this disease process. So that hopefully will be useful for you. There's another mechanism that we'll talk about a little later. This I wanted to share I spent a lot of time my first couple of years using silver diamine fluoride robustly in clinic myself in independent practice, trying to figure out why some cavities kept growing and why some did not. And there's a lot of ideas around that, but one of the key ideas that I've learned from the masters, from Dr. Graham Craig, who has been doing this in Australia since like the 1980, I think it was, is the idea of cleansability. Has anybody heard of a plaque trap before? Right, the plaque, it's nasty stuff. The bugs stay, the sugar comes in, and it festers. It's festering. That's literally, it's festering in this situation. That is the least likely situation for silver fluoride on its own to succeed in caries arrest. Now, if we can put it on 5 times in 3 months, I bet that'll be arrested. and it'll need reapplication periodically. If we could seal that to make it not festering, not a plaque trap, make it cleansable, that's great. If we can, polish it down so that it's not, that also can help. But the idea of cleansability is a very important one that dictates outcomes, longer term outcomes with silver fluoride. I have found this to be very true. This has been replicated in the clinical studies looking across hundreds of kids. It also translates to when there's not an actual cavitated caries lesion, to just contact points, just the anatomy of the teeth. Between baby molars, there's a very broad contact point. So if you have an initial caries lesion between baby molars, that is one of the least likely situations to succeed, even if the lesion is not cavitated. Now, depending on how frequently you have it, depending on how much sugar, strep mutans is going on, that'll raise this number up to much higher success or lower this number down a little bit. But it's the anatomical features that also contribute to cleansability and things festering in place. And that will have a huge impact on the success of silver diamine fluoride. One of the ways we see this play out is that the contact points in the anteriors of all teeth are just much smaller, right? And we know there's exceptions, like, as we know, if we have malocclusion, all those things, and those contact points are the most likely to have caries, right? So it's just all the same lessons that we've learned from seeing the pattern of where cavities happen and how they grow also apply to silver diamine fluoride outcomes. Hopefully that's useful. I'll give two pictorial examples, which we all love to see pictures, and that's why one of the reasons that we're in the oral health field. This was done by a dental therapist in Australia, kind of like a hygienist therapist combination. Kathy Boyce is amazing. Where there were cavitated caries lesions on these baby teeth. She treated with silver diamine fluoride, and the caries lesions arrested successfully. I think this was 2 applications for this kiddo. These are cleansable. They could get a toothbrush in there. It's not trapping every little bit of sugar that gets in there. These were pretty predictably successful because of the cleansability. Could you seal that one up? Is that a little bit, I don't know, maybe you need to look at it in real life and see, is there, but overall, these are pretty open lesions that can be cleansed by the saliva, by the tongue. Food's not going to get stuck in there. That's going to have a very successful outcome in general. This is my kiddo, not my child, very sweet kid. She was 2 years and 9 months, 6 months before this picture. She was 2 years and 9 months. Mom brought her in. How often do we wish a 2-year-old would do that? She just laid back. It was like the first time to the dentist. They had read some book about the dentist, and she was just like, ah. It's amazing. I probably could have taken x-rays on her at that point, but all 4 of her second baby molars were in and cavitated caries lesions. I put silver diamine fluoride on her in that actually it was silver nitrate and fluoride varnish that day. 3 months later, brought her back, silver nitrate fluoride varnish. 3 months later, I just looked, and all the cavities had grown. Clearly, I don't have a photographic memory, but all the cavities, clearly it was bigger. And we took some X-rays. And it was like May 20th, 2015. And so it was like April 30th, 2015, we got silver diamine fluoride in the United States. So I was like, now we got the real stuff. That Steve Duffin guy must be crazy. Let's use the real stuff. Let's try this again and see what happens. So I put silver diamine fluoride on her again, and in 3 months again, and then she came back and we took another X-ray and looked at the teeth, and it didn't work. It didn't work. So if I haven't made the point earlier, it turns out silver diamine fluoride and silver nitrate fluoride varnish are exactly the same efficacy. That man's a genius. All praise due. The point here is to assess at 6 months. Also, right? It's like, these were cavitated, these are a plaque trap, these are not cleansable, they were holes that you could not get a toothbrush into, but the bacteria were in there, the sugar was getting stuck in there, that it didn't work. Using this in terms of following up for clinical practice, one of my messages is at 6 months, if the lesion has grown, do something else. That's been one of my take-homes. If you look at the clinical trial data, at 6 months, like 45% of these cavitated lesions, in general, cavitated, cleansable or non-cleansable, will have arrested at 6 months. 20%, give or take, could be 10%, 30%, will have grown. Those need something else. 35% won't yet be shiny and hard, like freshly cut dentin, like sound dentin. It won't be arrested yet, but they also have not grown. If you just stay the course, those will arrest with time. They don't seem to need anything else. If it has not grown, you can keep just applying the simple medicine. Okay, so that was sort of outcomes, and these are 2 more tools and then 1 message around products. This is a tool for you for your conversations around fluoride. I, for the last 4 years, 3.5 years, have been, 4 years, have been practicing in an area that's a lot like a lot of Oregon. A very anti-fluoride, very anti-vax, back to the roots hippies, back to the roots conservatives. Nobody wants to be told what to do. Nobody wants fluoride in their water. Nobody wants fluoride on their teeth. So I have never once had anyone say no to silver diamine fluoride because of the fluoride. I mean, initial no, absolutely. And I'm not trying to convince anybody. I'm just giving information about an option. And they say, I don't want that terrible fluoride stuff. Okay, let's talk about it. If you came to San Francisco and you were at my house and I handed you a cup of water and you knew that it was fluoridated water, would you drink it? Yeah. So if you were in San Francisco long enough that you would have a 2-liter, I know I need a 2-liter bottle of water. There's no 2-liter bottles of water. If you had enough water that was a 2-liter of water in a year or every 6 months, would you be okay with that? That is how much fluoride there is in 1 drop of silver diamine fluoride. That drop of silver diamine fluoride, we are going to get into your tooth instead of throughout your body. That has been helpful for people to understand the enormity, magnitude, and distribution through the body of where the fluoride goes. And I'll show that to you. Does anybody have, like, if you're in a physical clinical practice, like on your screen, you have like a little like folder where you can like click to look at pictures with patients so that they can understand, like, this is a tooth before a sealant, this is a tooth after a sealant, any kind of images that help your conversation, help people to inform people, empower people about like what the hell you're talking about. This is one for me. And I always get like a double tickle. Are you really trying to show me a chart right now? What the hell is wrong with you? I'm like, no, like, stay with me. Every time. Like, you are a researcher. I'm like, I know, but just look. So these are 2 different studies of the level of fluoride in the bloodstream after careful silver diamine fluoride treatment. If you look at this for fluoride varnish, it goes spike and comes back down within like 8 hours. In the little kids, it's even quicker. It never goes up. It never consistently goes up in any patients with careful application because it absorbs into the tooth. Now, do you care about fluoride in your tooth or do you care about fluoride in your body? And if they care about fluoride in their tooth, then you shouldn't have this. If you just don't want fluoride, then that's not going to work. But it actually does, there's no measurable systemic absorption of fluoride as long as we are carefully applying it into caries lesions or high-risk surfaces, and we remove excess afterwards. So that's pretty cool. Another thing is that there is 7 times the amount of fluoride in 1 packet of fluoride varnish as compared to 1 drop of silver diamine fluoride. So the image means that you need 7 drops of silver diamine fluoride just to get as much fluoride as it is in 1 packet of fluoride varnish. So overall, my philosophy that I've come to personally, practicing in anti-fluoride country, is to try to maximize the benefit from any kind of fluoride by maximizing the concentration and minimizing the number of exposures. So I would much rather somebody have silver fluoride on their teeth once a year to prevent cavities than them brushing with fluoride toothpaste every day. I think the effect is much stronger from that 1 exposure, and the physiologic exposure is way lower. Now, I want them to brush with toothpaste, right? Like, come on, God. But they don't need to have fluoride toothpaste from my perspective. It's not required. It's not going to give them cavities or stop their cavities completely, right? It influences it. It's a big deal. But if they're saying no to that, you know, maybe they would choose this for themselves. So again, I will put my email up, and you're welcome to any of this information, any of these slides. Happy to share the references. I'm trying to empower you and give you tools for your fight that you're already having, I know, as some of you have shared with me. This is where I'm gonna like go completely off. So for anything where you get continuing education credits, you're not supposed to talk about like products unless there is like a really important reason to do so. And I think that there is an important reason to do so. There are 3 silver diamine fluoride products that are sold in the United States right now. There's also silver nitrate and fluoride varnish. Silver nitrate and fluoride varnish appears to be no problem with that in terms of safety or efficacy. Silver diamine fluoride, the Advantage Arrest product from Elevate Oral Care, seems to be no problem with safety or efficacy. It works. There's 2 products from SDI, Rivastar and Rivastar Aqua. Rivastar is, sorry, I should take a step back. The Elevate product and all the other products around the world that aren't available here are about pH 9, pH 10. 7 is neutral. The further you get away from neutral out to like 1 or 14, the more dangerous it is. Elevate's product is 910. All the other products in the world are about 910. Rivastar is 13. Think bleach. It is intense stuff. It burns. The FDA has recently made public that they have seen this. There are warnings now that it will burn soft tissue. This product it arrests caries just as well. But it is not safe to be used unless you have really good isolation or really careful placement. It arrests caries just as well, no problem. There's a second step for both of the Rivastar products called potassium iodide. Super safe. They claim that it doesn't, it's the non-staining SDF. This is the effect of the non-staining SDF. So obviously there's no color change whatsoever, right? Everybody see that? Goes from this color to it's the same color, right? So this is what you can expect from the non-staining SDF. It works just as well, totally, but the non-staining stuff is garbage. It's just not true. And they can keep saying that because nobody is regulating it. So the potassium iodide is fine, it's safe, there's no problem with it other than it just doesn't do what it's supposed to do. The third product, Rivastar Aqua. I don't know how they're selling it in the United States. It's actually not cleared by the FDA. It's kind of this weird thing. But it has been used in Australia for a little while, and it works. It stops cavities. It's pH 5. So you can think about 7 up to 9 or 10, 7 to 5. It's good. It seems to not smell or taste bad, which is a huge win. It's a huge win. They sell it with the second step of potassium iodide. The chemistry is different with the Rivastar Aqua. The potassium iodide literally makes it ineffective. So if you use the pH 5 Aqua stuff on its own, it works, you're fine, you're good. It's a little different, but it's fine. Just throw away the potassium iodide bottle because it will render it completely ineffective. I am trying to work with that, with the people that sell it, the shine, so that they can tell SDI, because we've told SDI enough times. But just, so those are the 2 things in terms of safety and efficacy around the products. Hopefully I was fair and objective in those things. And I am biased because I do love the Elevate folks.
So what's causing that?
What's causing that? So there's a little bit of nitric acid in the Aqua product that lets it be stable without ammonia. And the iodide interacts with the nitric acid in a way that binds silver and doesn't let it work. So it's some kind of that, and it's actually, they were both invented by the same person, the potassium iodide step it's for non-staining under glass ionomer fillings, not for just, open treatment. It was invented by the same person, the Aqua and all that. It's like, you can't combine these. And now we have a clinical trial that says just don't combine them. But yeah, it's the chemistry. They're not meant to be with each other. It is a little nerve-wracking to be talking about glass ionomer in front of my glass ionomer mentor Dr. Doug Young. I only know things about glass ionomer really thanks to him, so I will keep this relatively simple and focused, and he will throw things at me and correct me as I speak wrongly. Everybody heard of glass ionomer before? Cool. Glass ionomer is a filling material, it's a sealant, it's a eluting agent, it's stuff we put on teeth to make them better, right? I find it interesting to think about the chemistry as we get through all these different iterations of resin-modified glass ionomer and the new glass hybrids, which is like Equia Forte and Keitac Universal, and the sort of the classic glass ionomers like Fuji 9 and all the others. I find it helpful to think just a little bit about the chemistry, and so I'm going to do this in the way that I understand it. I'm not dumbing it down, this is how I understand it. Is that when you have your liquid and your powder, you have the powder's little glass particles, and the glass has a bunch of magic metal ions in it, and fluoride. So fluoride, aluminum, strontium, other things, it can have metal ions. The liquid is an acid. It's a weak acid, it's polyacrylic acid, whatever that means. It's a weak acid that has this sort of long chain with all these little acid parts coming off of the chain. When you mix them together, the first thing that happens is that the acid actually leaches out metal from the glass particles. So it helps all these little metal ions and fluoride ions release out of the glass particles. And this is the phase where we are putting it on teeth. Mix it, get on teeth. As soon as you start to get ionic bonds between the metal and the acids and the glass particles, that's where you enter a different phase of the chemistry when you need to not touch it, when you can really screw it up. When if we just protect it and let it set and do its chemistry, it'll turn out beautifully. The differences in the materials can be as such. When you have this polyacrylic acid molecule with a little acid thing sticking off, if you make that really, really, really long, it turns out you really enhance the physical properties long term. You increase hardness, strength, wear resistance, all the good things that dentists really like. And that's what the newest glass hybrids are. It's the same stuff, just much longer. A lot of dentists, and I don't know if this is familiar for you, but we like ribond. When we do plastic fillings, we like to put fiber in it. It's like putting fiber in glass. The more long strands you have going lots of different directions, you have like fiberglass, which you can walk on, but you can't walk on glass. That's how I think about it. It's not exactly a perfect one-to-one, but it's pretty good. The other modification that we can make is putting resin in there. Now, why would you want to put resin in there? If you are dealing with little kiddos and you're trying to get stuff in really quickly as you can, and get the kiddo like to be able to live a normal experience outside of you being in their mouth as soon as possible, it can help to have a light cure. It can help. You could probably, I try to use it as little as possible, but I still use it. So if you have a little bit of resin in there, what can happen is you hit it with a light, and it's kind of like a scaffolding. It's like sort of like a backbone that can get in there and solidify quickly to help protect this reaction while it is still happening for 4 minutes, 1 minute, 1 minute, 3 minutes. So the initial resin set, if you have a bunch of resin going through here, it can help to just kind of protect things, maybe while you're taking out your wedge and letting the patient run around a little bit or whatever's going on. It can help. If you have too much resin in here, it will interfere with the chemistry and prevent the metal ions and fluoride ions from coming out of the material after it sets. Resin not only bonds, but it binds, and so it keeps things from going out. If you ever put silver fluoride and then resin, the whole thing turns black. Not right away, but it's like grabbing all the silver fluoride into the resin. That's what resin does. That's fine, but it makes the more you have in there, the more inactive the glass ionomer is going to be. So there can be a balance in there. So that's how I think about glass ionomer. I want to have pure glass ionomer wherever I reasonably can. If I get these longer chains in there with the newer materials, we're going to have better properties long term, but it's thicker, so that it has some handling issues short term. Of course, we have a playbook page about this, which we're pretty excited about. And I hope you can see from wherever you're at that there's a finger here adapting the glass ionomer onto the tooth. I use the same technique to place glass ionomer sealants with like a Fuji 9, like a classic not too thick glass ionomer. This is what I do. Or a filling, or somewhere in between, as a lot of us do. So there's a bunch of lessons here. I'm not going to go too deep into the details, but some of the key issues are keep the area moist, work fast, and use the sensitivity of this material to your advantage. Right, so resin, the only good thing about resin is that you can light cure it, as far as I'm concerned. That's the only good thing, and they've made very pretty resins. With glass ionomer, you have 1 minute to put it on the tooth and stop messing with it. And then you need to protect the reaction for a few minutes. Well, what that means is that you can do tricks with that. It can be really fast. So I can place, I do it all the time, I can place full mouth sealants on 12 patients in an hour. And we have to actually have a kind of conversation and consent and all that stuff ahead of time. But we do that. I can't do that with resin sealants. You have to isolate and all that stuff. So you can use some of these features to your advantage and increase your success. So again, the point is sort of while that initial, I'm going the wrong way, sorry. While that initial chemical set is happening, the hydrogel phase, that's when you're applying this material. And then once it starts to set, you need to leave it alone. So what we do is we clean the tooth, we use our conditioner, mix it as fast as possible, get it into the applicator gun, and get it onto the teeth. We do our quick adaptation. I like to have a little Vaseline on my finger. My mentor, Doug Young, says just use water or saliva, don't use, or just use your, but I like a little Vaseline. I'm just stubborn. Or wetting resin, so that the patient can then articulate and bite down, do a little excursive movements, and they've just finished your occlusal adaptation for your sealant or your filling. They open, and the only part that I am touching after they open is parts of the material that are not going to stay. I've got it over the marginal ridges, I've got it off of the contact points, and now I'm just pulling away while we might be into that key polysalt gel phase where it's all binding together. I'm only pulling away parts of the material that's not going to stay anyway, so I don't care if I'm agitating it. So that's kind of the magic application of glass ionomer that we do to enable full mouth treatment very rapidly. Easy for the patient, easy for us. You get the medicinal effect of glass ionomer, of these ions going into the teeth. It increases retention, increases therapeutic effect. So that's pretty exciting. I promised myself I wouldn't go into too much clinical trial data, but just I think this is something that keeps coming up. We did have a fight with the Oregon Health Administrator, was it OHA, about whether glass ionomers could be used for sealants. We won, yay, it was a few years ago. And this is one of the pieces of information that helped, but obviously not everybody knows about it, so I just wanted to make sure you saw it. This is a type of plot that increasingly people are using to show the combination of clinical trials, right? You can't trust one study. We need to look at multiple studies, and this is a way of synthesizing, of summarizing the data across multiple clinical trials. In this case, each of the squares and these whiskers represents one clinical study with hundreds of people in it. And we try to get, it's called a forest plot, because you try to get the forest view where each of the trees is a clinical study. And the diamond is the forest view. If the diamond overlaps this line of no difference, this line of equivalence, that means they're the same. We can't statistically, from all these studies, tell the difference. And basically, resin versus glass ionomer sealants, when you look at caries, when you look at cavities, there appears to be no difference in terms of the incidence of cavities after sealant, after carefully placed sealants. That's great. We can't always carefully place sealants, right? Sometimes the places that need it the most, like I can't isolate in a Head Start, for resin. No way. And one of the things that's interesting is that the further out it goes, the more it seems to favor glass ionomer. We believe that's because of the medicinal effect on strengthening the tooth with the fluoride and metal ions to resist cavities. So if that weren't enough, there's another study. This is one of my favorite studies where they took 2,500 kids in Italy, and after 2.5 years looked at the following question: does the sealant material that's used, the material itself, does that prevent cavities on the tooth next door? So they put some stuff over here, does it have an effect on cavities there? Different tooth next door. And the answer is yes. So the answer is that by using glass ionomer instead of resin, you get a third less cavities nearby. This is one of the pieces that convinced the World Health Organization that this is a medicine. That we're not just having, an inert block barrier. We're actually having something that has an effect on the surrounding area to strengthen the resistance to this sugar-borne disease. So that's pretty exciting. So, if you can seal teeth with a material, and if you can have a medicinal effect on teeth with a material, why could you not then use that to seal up a caries lesion without excavation? Why could you not use that on demineralization or caries? So for over a decade now, or about a decade now, the American Dental Association, thanks also to Dr. Young, has been saying seal in caries lesions and use glass ionomer. Use resin or glass ionomer, but seal early non-cavitated caries lesions, demin, white spots, whatever you call it. Seal them, and why not use something that's actually therapeutic? Does everybody know what a early non-cavitated caries lesion is? What Dr. Young led the naming of initial caries lesion is the ADA terminology now going forward. Does everybody know what that is? I don't think everybody knows what that is. Maybe you guys all do, but here's some examples of the studies that went into that recommendation. These are pictures directly from the studies. So this is at baseline. You can clearly see radiolucency in the dentin. That is a non-cavitated initial caries lesion. That is demineralization, that is not bacteria in the teeth, because the enamel is intact. Yeah, there's some staining and maybe there's some widening of the enamel, but they said the enamel's intact, let's seal it up. How many dentists that you know would say, yeah, don't drill that, just seal that? That's what the ADA is saying. That's what the ADA is saying. This is the highest level of evidence. This is the best we have for this. This is not a hole in the tooth. We can see enamel over that radiolucency. I'm looking at the tooth, the enamel's intact, it's widened, the fissure's widened, but we can seal that up, that's gonna be fine. You can show this to people. I do, obviously. And so there's different studies. Some of the studies do sealing with versus a control group that gets nothing. And let's just say bad things happen in the control group, so this is a population with disease. So it was like in this group, it was like 96% of the control group cavitated and got worse. There's other studies where they do this versus fillings. And I love it because it just shows that they're treating a diseased population where things get worse if you don't do anything. And the fillings, they're doing really careful fillings where after the year or 2 years that the study goes, all the fillings are fine, they're good. And in all the studies, what you see is maybe like 1 or 2 of the sealants, the lesion grows underneath and it needs a filling. So what they keep finding with all these studies that are done is that if you just seal it, you're preventing like 95% of fillings. Nothing's 100%. I'm sure the fillings aren't going to be 100% long term, but just seal it, and then yeah, some of them will need fillings eventually, but not the vast majority of them. So this, hopefully will be ammunition for you. Also, I'm not going to get too deep into this study, but this is also one of my favorite studies. So this is where they use like Delton sealants, old resin, the first generation resin sealants, to just seal over cavitated dentin lesions. They did a 10-year randomized clinical trial. 10 years. This is like the only 10-year study I know in dentistry. And they found that sealing carefully, where you have access to healthy enamel all the way around the caries lesion and the pit and fissure system, so you can really seal it, that had the same outcomes as amalgams, as a standard carefully placed amalgam filling. And if you sealed the amalgam, you did an amalgabond, sealed amalgam, that had even better outcomes. So we can combine these things together. But this was with Delton sealants, and we have these amazing glass ionomers now. Nobody would try Delton sealants anymore. So just to show, and this was published in the Journal of the American Dental Association the year I graduated from high school. So when I was talking about this paper, it was like 2008, that wasn't like that long ago. I'm 40 now, so this was 1998 this was published. It's quite a while we've had this information. And it was published in the ADA journal, so this is not like fringe science. So we conceal these things. And I hope that you can realize the implication is that if we don't need to excavate, then hygienists can treat all of this. So maybe you guys already know all that, but the whole rest of the world doesn't, and the rest of the country doesn't. The lack of adoption of using sealants to treat early caries lesions in Oregon is so perplexing that there are actually published papers studying what the hell is going on with the Oregon dentists. Seriously, there's published papers that are like, okay, like you guys are on a capitated system for your Medicaid and you're still not sealing in initial lesions? The American Dental Association has recommended that you do this. So it's so perplexing that there's research being done on trying to figure out what's wrong, trying to figure out what is the decision-making process that's going on. Really? That's how weird this is to the rest of the world outside of dentistry. Like, why are we not doing this more? All right, sorry. So, I try to empower people, and so one of the tools that we have to empower people to seal in caries lesions is this idea of SMART. SMART's a lot of things. A few of the people who created this term are in the room. It's supposed to be silver modified atraumatic restorative treatment, where atraumatic restorative treatment is a scoop and fill glass ionomer. It has lots of names. There's now a project in Oregon, which one of my heroes, Ashley Danielson, is involved in to do ITRs or IRTs or whatever people want to call it. It's art. And if you put silver diamine fluoride as part of that, it's SMART. There's particular tricks that we use, though, which should empower us to be able to treat cavitated or early caries lesions without anybody worrying, to get over that barrier of what's wrong with all of us that we're not doing this more. And that's why I'm telling you about SMART, so hopefully this will be useful. So, what's the basis of a restoration? What do we need to have underneath a filling? And I know all of you learned this in hygiene school, and then you haven't really been allowed to do it as much as you should. It's very silly, and I get people complaining to me about it all over the country. But the goal of a filling, restoration, is to seal out bacteria, seal out nutrients for the bacteria, and to have a hard, and you need a hard foundation to support the filling, right? It turns out that we accomplish these things with the combination of silver fluoride and glass ionomer. We talked about two mechanisms of silver fluoride earlier: kills bugs, makes it hard for the bugs to grow back. The third thing is that it hardens carious dentin. Sorry, this is gross, I know, but we look at teeth all day, so this is, has anybody ever used a silver nitrate stick to cauterize a bleed, to stop a bleed? No, not familiar. Okay, so this exists. Silver nitrate is used on bleeds to stop them. You could just put a little silver nitrate stick. All the oral surgeons have it. Anyway, you just put it on, and it just coagulates the blood. It creates a scab like that. It's amazing. So if you ever accidentally cut somebody, nothing? I was gonna be a little black dot here for a couple days. Sorry about that. For real though, it's definitely. But what silver does is really amazing, and you don't need the fluoride for this, is that it denatures all of the proteins in a way that then makes them condense together and bind to each other and harden. It's not that different than the glass ionomer reaction. There's a metal ion interacting with these other ions, acids and otherwise, to facilitate, to compress, condense, and harden. So if you think about exposed dentin proteins, carious, the bugs, all that stuff, it condenses down and hardens. So what we see that turning into is that if you treat a carious lesion, a cheesy, nasty carious lesion with silver fluoride, and I'm sure most of you have seen this before, then it hardens, it becomes hard, it arrests, right? We don't always get caries arrest from just one application, right? But pretty much always the lesion condenses, it becomes less active, and it hardens. So when it hardens, that can be a foundation for a restoration. What happens is the silver and the fluoride, the silver goes into the dentinal tubules and precipitates out as solid silver metal. That's like taking cement that's been weakened and pouring rebar into the cement to strengthen it. That's incredible. The other thing is this layer up here is this incredibly dense scab, but it's a metallic scab that's basically it's taken all that mush and turned it into a really solid foundation. That is harder than freshly cut dentin, and so we can use it to place a restoration on it. I do it all the time. We call that a smart filling. This is an example from John Fricella where you have glass anomer. I call this the watermelon slide. Doesn't this look more like a watermelon than a tooth? This is glass anomer. Down here is the solid silver filling in the micro cavities, the little holes that the bacteria make down in the tooth. And in between, I don't know where one ends and one begins. The silver and the glass ionomer sort of are fused in with the tooth. But that's what we're seeing here, and this provides a very solid restoration. To put the playbook together, we paint silver fluoride, we clean the tooth, and we can come back later. One of the things I haven't mentioned, oops, I keep pushing the wrong button. This takes time. We did it in the laboratory. Steve, you remember at the Advanced Light Source in Berkeley? It's like, is it The Incredible Hulk? If you've watched the more recent version of The Incredible Hulk, where he like smashes the whole like really crazy looking laboratory with wires and pipes and magic lasers everywhere. It was there that we did this work. It was incredibly cool. It was so cool. You would, yeah, totally. It's just up the hill from you. Have you been there? Oh man, yeah. Anyway, it takes like at least 3 days for these silver solids to really start forming and start really hardening. So this doesn't happen immediately. The initial reaction at the top starts immediately, but for some reason, this whole process takes a few days. So you do have to come back later. So you put the silver fluoride on when you see the lesion. You come back at least 3 days later. My rule is 1 to 6 weeks if I can. Sometimes 3 months will do. And you brush the teeth, little conditioner, dry it. Sorry, not dry it. Dab the excess liquid away. And then put your glass ionomer in, adjust, bite, good to go. So I do this all the time. It's become my standard way of treating cavitated caries lesions if I can access the entire perimeter of the tooth. And I don't have anybody freaking out about this, oh, you're sealing caries in, because I've treated the caries with silver diamine fluoride. I've had an initial hardening. We're going to use the medicinal effects of the silver fluoride and of the glass ionomer to prevent recurrent caries, to control any remaining bacteria underneath, and to seal out the nutrients and other bacteria from invading. So this was a kiddo where saw them, cavity, what do you want to do? Cool. All right, let's talk about your food. And yeah, no, we can put some silver fluoride on it. Is that cool with you? All right, cool. There's gonna be a little black dot. No, it's a much better conversation than that, I promise. They came back after the silver fluoride, tooth was black. Toothbrush, conditioner, dab dry with a 2x2, glass ionomer, Vaseline, finger, bite down. Oh yeah, we also sealed the 6-year molar and the first baby molar at the same time. Why not? They came back 6 months later. That's what it looks like. This is routine for me. And of course, the point of sharing this is that you can do this too. This is a longer story as well, but a teeth that I had treated with silver nitrate and fluoride varnish, that then it came back a different time and applied glass ionomer in to try to get some of the therapeutic effect of glass ionomer. This was early 2014, and these teeth exfoliated looking like that. So you can see there's some black around the edges, some show through, but clinically, everybody's happy. We have, for a while now, been applying this to molar incisor hypomineralization. The clinic that I most recently worked at, 100% of kids who had teeth like this were put into general anesthesia. It has become routine now to use silver fluoride and glass ionomer with no local anesthetic, no drills to stabilize these teeth. So kid comes in severely phobic because they've been to other dentists usually. They don't want to open their mouth. We talk, get comfortable, let them take a break, I'll go talk to somebody else. talk, get comfortable, take a break, go talk to somebody else. Silver fluoride without drying, maybe without putting a 2x2, just swallow, open, sitting up. Silver fluoride, I do my best. We're good. Come back at least a week later. Then I can dry at least with a 2x2. They just became my best friend because they just had the first drink of cold water they've had, and it's 2 years since the tooth came in or whatever. And I carefully apply silver fluoride a second time in situations that are this bad. They go away again, they come back a third time at least a week later, and now they love me. And we're all good. They have no problem anymore. They just had ice cream. They haven't had ice cream. They hate ice cream, but now they love ice cream again. And then they lay down, and we can, brush the tooth, put some conditioner on. When a tooth is this broken down, we put an ortho band around it. We cement an ortho band. And then after the ortho band cement sets, then we apply glass ionomer, and I just adapt with my finger. I show this to everyone so that you can see it's okay for you also to not have any occlusal anatomy, whatever. A year later, we talked about the possibility of the tooth sliding laterally or whatever, lingually or buccally. So I developed some occlusal anatomy with a high-speed handpiece and a lot of water a year after taking this picture, because who cares? Well, long term it should have occlusal anatomy, but short term it didn't need it. And now that's what her teeth look like. All her teeth look like that. So we do this routinely now. If you apply silver fluoride and glass ionomer the same day, you guys probably all know it'll look kind of more like this. The stain kind of goes through the material, especially at the margins a little more. And it also enables us to do things like this. This was just wonderful. This was a 2-month-old kiddo who actually the mom saw some of Jeanette McLean's work on social media, where moms were like raving, "Oh my God, like my kid." And so I met this kiddo after she had already had her cheek treated with silver fluoride. I wasn't sure really. It had been like 6 months, and the kid was only 2 years, 2 months. It was kind of rough. It wasn't really that hard. So what we decided to do together was to place silver fluoride again, have her back at least a week later, and then we fitted some crown forms, some strip crown forms, toothbrush, conditioner, place 2, held it there while singing in mom's lap with no nitrous oxide, no needles, no drills, for that full first minute, held the forms on, then moved my fingers to the rest of the mouth to hold her open so that she wouldn't jostle the crowns, and I wouldn't jostle the crowns while we sang for another 2 minutes, and then let her go play, run around. I went and saw another patient, she came back, and we did the laterals, and I took the forms off after another break. Is there black show through there? Sure. In a 2-month-old, this is wild success for me. And that was no needles, no drills, all things that you can do. So we just have a few minutes left because I talk too much. I do want to make sure to talk about 2 more topics, iodine and Curadigm, just briefly. I have a whole hour-long lecture about iodine on the Elevate Education website. I welcome you to do that. You can get CEs through that. But povidone iodine, again, hygienists in Oregon are probably the only people who have been using it anywhere for years for prevention. So what am I talking about? Using iodine can prevent caries. Iodine, betadine, like the stuff used on your wounds, the stuff that turns your skin a little orange and then it goes away, does not stain teeth. And you can put it on immediately before fluoride varnish or instead of fluoride varnish, and it works. Any povidone iodine. There are clinical trials. There are non-randomized clinical studies and randomized clinical studies. Overall, they point to about a 1/3 reduction of caries at the patient level. So a 1/3 less people getting cavities. Usually we talk in terms of teeth. In terms of teeth, it's somewhere around 50%, a little higher. We don't have good numbers on teeth because all these trials are reporting who gets cavities versus who doesn't, not which teeth. So fluoride varnish doesn't do that. So this is actually pretty profound. You can combine it together Lots of details, but in particular, I have been trying to get people to do this since like 2012 with just a bottle of betadine, a cotton applicator, remove the excess with some cotton, and just apply. And yes, you can put fluoride varnish on afterwards, immediately afterwards. So, I mean, how I do it, I literally like 2x2, iodine, fluoride varnish, just like that. And I've had such a hard time convincing anybody to do it, except for like the community care team in Oregon, that I begged and was well received at Elevate for them to create a povidone iodine application device that is dosed for safety to make sure that people can use this at their own homes and not overwhelmed, so that dental providers can use this in their practices wherever they are and not apply too much iodine to make it unsafe. So that now exists. We have this as a playbook page. There's a lot about the safety that is just, there's a lot of misinformation out there. Can you imagine misinformation? About safety of iodine, like the shellfish thing is a total myth. That's totally been disproven. It doesn't stain teeth. Like you put it on the teeth and you stay open and you're gonna come hit me in the face because it'll make the teeth orange. Just close and open again and it goes away, the color goes away. Soaks into the teeth real fast, kills bugs, and keeps bugs away. Not as strongly as silver fluoride, but pretty darn good. So this has been in the works for a long time in dentistry. You're gonna see more and more clinical trials and more proof on it. More and more publicity on it. And I think the Elevate folks. One of the things that's done here, I don't want to even try to understand this slide, but it's a reminder to me to say, it actually shifts the bacteria. We've been looking for something that actually shifts the bacteria. It has positive shifts for caries bacteria, and it has positive shifts for periobacteria, which is really exciting, right? It really does. It's consistent. It seems to work, and that's the mechanism. So if we have remineralization with fluoride or healthy diet, we shift the bacteria with an antimicrobial that doesn't stain, that can be used at home, can be used anywhere. Now we're really getting somewhere. Yep, Karen?
So the frequency, if a patient was to use this at home to manage their biofilm, what is the safe frequency for them?
Yeah, what's the frequency of application for povidone iodine at home? For caries, thank you. For caries prevention, the studies show anywhere from every 2 to 4 months. So every 2 months, or every 3 months, or every 4 months, all has a preventive effect. You just need to keep placing it over time. So there are studies where they placed it once and then never again, and it didn't have any effect. Like the strep mutans disappeared and then slowly came back and the cavities kept coming anyway. But if they kept placing it quarterly, seasonally, that had a massive effect on caries incidence.
And this could be used in an adult population in long-term care when you can't, a caregiver can do this at home.
So one of the things we're trying to do, thanks to Karen, is that caregivers can do this at home. Nurses, aides in long-term facilities can do this. They have povidone iodine. They know povidone iodine in hospitals and nursing facilities. It's a wild idea to put it on teeth, but we do have a bunch of safety data, which in the Elevate talk I go through. Sorry, but just briefly, this is my favorite thing. So this is the standard of care for mucositis in kids or anybody who has bone marrow transplant or chemotherapy where they have mucositis. This is the standard of care for prevention, intraorally, where they scrub povidone iodine in the mouth, and for decreasing the severity of mucositis. So if you look at the clinical trials that are done to try to find something better, they compare this as let's not call it a gold standard, it's a wood standard. Mucositis still sucks. This helps. It's horrible stuff. But they put this on the mouths of people who are getting bone marrow transplants and their mucosa is falling apart. And so if that doesn't indicate that intraoral use is safe, I don't know what does. So it's unfortunate that's happening, but it does tell us that this is very safe for intraoral use. There's also more of a discussion about these things on that. And here, I have the URL, I'll put it up later. But basically, this is what I do on my kids. I put iodine on their teeth. quarterly. It's easier for me than trying to convince my wife to let me put sealants on their teeth. Just put some iodine on it. Cool, cool. And if parents can brush the teeth, they can place iodine too. Right? It's no more complicated than brushing the teeth. So this could be a win to give to people to use at home, in schools, in nursing homes, adult care, and it doesn't sting. Pretty simple. So I'm going to take the liberty, if it's okay, of just 2 more minutes to talk about this other material that we're really excited about, and I'm totally biased on, but I've been spending a lot of time on, and therefore, hopefully that's a demonstration that this maybe is useful for you. There's this new thing, it's coming, called Cure.Repair. It's a designer peptide. It's 11 amino acids long. What is that? It's a little piece of protein that you apply to white spot lesions, initial lesions, and it soaks into the lesion, and then it assembles. It's like a ladder. It's like you throw a bunch of rungs of a ladder in a pile, and then they turn into a ladder. It self-assembles into these fibrils, and the fibrils pull calcium and phosphate from the saliva to rebuild, to fill in with hydroxyapatite, to rebuild, to template the regeneration of enamel within micropores. We're excited about it. There's clinical trials on it. The trials are not huge. They're not long term. It does depend on changes for the patient. What are the 3 mechanisms of silver fluoride? Kills bugs on contact, really keeps the bugs from growing back in, and it hardens the tooth. This hardens the tooth. So it doesn't change the bugs, and it relies on the health of the saliva, calcium and phosphate, and not a continued disease process for it to work. If those things are in place, which is a big if, it works. And so we have a big study in Oregon and other states rolling this out, and we believe in it enough that we've treated 3,000 teeth in 962 people of all ages, and we're watching what's happening with it. So we're going to watch for the next 2 years after each treatment for initial lesions. We're excited about it, and in particular, right now it's pretty expensive. It's a designer drug. It's like $30 for something that you can treat 1 to 3 teeth with. But our involvement, my group's involvement, there will be a product launched around June or July of next year where it'll be about $15 when you can treat really as many teeth as are in the mouth. The existing device is really inefficient, to say the least, but specific to kind of Medicaid, OHA types of patients, Medicare. So it's only going to be available at that price for sort of public health scenarios. And so that's what I'm doing. So I wanted to share with you that that's coming. I think it's a little ridiculously expensive right now, but all new drugs are. But the people who developed it are kind enough to offer it basically at no profit to them whatsoever for the public health setting, where it should be launched around July. So that's exciting. It's coming. It also could be used at home. So we're working on figuring that out. Nobody's selling it for home use right now, but the way that it is through the FDA, just like iodine, this could be used through teledentistry with people staying in their homes. It could definitely be used in care facilities. It's not for dental lesions, it's for enamel lesions. But we're excited about exploring the possibilities of it in the future. So with that, I'm going to put my email up again. I thank you for your time and for sharing this moment. And I'll stop. Thank you. Can we do a few questions before we take a break? Is that all right? Just a couple. Over here.
You mentioned the codes that you bill under. Is there a code?
For?
The SDF?
All right, codes. You ready?
Yeah.
All right, happy to talk on the break on details for anybody who needs this.